So good afternoon to all of you. So we are with another learning session. So that is again the competency is PA 4.4 continue. So that is about another acute inflammation, another organ that is involved by acute inflammation. So what is it? It is lobar pneumonia. Pneumonia is such a common terminology and everybody knows. I remember my grandmother was telling like so many of her very close relatives dying of pneumonia and all that. So it was such a dreaded and very serious illness. So what is pneumonia? It refers to an infection where of the lungs. So is it both the lungs? It could be one lung or both lungs. Okay, pneumonia consolidation is a usual terminology which is used interchangeably for pneumonia. What happens is this causes alveoli of the lungs to show the presence of, or you can say exudate, accumulates in the alveoli. Normally we see alveoli with air. Histology you have seen alveoli, clear spaces you have shown. So here in this pathological process, exudate accumulates in the alveoli, and this exudate also has in addition the causative organisms of the bacteria, viruses and all that. So certain terminologies you should remember. I have used the term lobar pneumonia here. We know that both lungs have lobes. Okay, right has 3, left has 2. So when we say lobar pneumonia, it refers to acute bacterial infection of a part of a lobe. So it could be entire lobe or large part of a lobe. It could be confined only to one lobe or one or more lobes, one lung or both the lungs. So clinical manifestations, usually patients present with fever, chills and rigors and muscle aches, difficulty in breathing, definitely yes. So when the alveoli have exudate, so how can breathing be easy, right? The pneumonic infection, this has been noted throughout human history. Even today we say many children die of pneumonia. So why I told you fever with chills and rigors is, so when we just entered second year, that is after completing 1.5 years of first MBBS, so we were taught about the causes for fever with chills and rigors. So the teaching for us was malaria is one, when a patient comes with fever with chills and rigors. Then second they said urinary tract infection. Third is pneumonia. Yes. So we classify pneumonia based on the anatomical, that is the part of the organ involved. So lobar I already told you. See, when the lobe is involved, entire lobe or large part of a lobe. It could be unilateral, bilateral. Okay. Then what is this bronchopneumonia? We call this as patchy pneumonia. See, it is not involving the entire lobe. So patches you can see. That means the associated, see, the bronchus and the alveoli surrounding are involved. This is bronchopneumonia. We call it as patchy pneumonia also. Then interstitial pneumonia. You can see that the interstitium is the one which is involved. So what is there in between the alveoli? So that is mainly involved. So this is another way to classify pneumonia. This is based on the etiology, that is a causative organism. You know what is etiology. So bacterial pneumonia, bacteria are causing. So lobar pneumonia is caused by bacteria. Bronchopneumonia, I told you patchy pneumonia, it's also called as lobular pneumonia. Then viral pneumonia is, sometimes they call this as pneumonitis, mycoplasmal pneumonia. Then other types of pneumonias, pneumocystis carinii pneumonia. So we were talking about this a lot during the days where when AIDS was so common. So opportunistic infection. Legionella pneumonia, caused by Legionella pneumophila, Legionnaire's disease. This is spreads through air conditioning system. aspiration pneumonia. So the food may enter, or it could be some particles which are inhaled. And hypostatic and lipid pneumonia. This is based on the etiology. Okay. So I was telling you about pneumonia, how dreaded disease it was. And we definitely have to remember Alexander Fleming, who discovered penicillin. You know, with the advent of penicillin, usage of penicillin after he discovered, so that was like a Ramabana, we say, you know, to treat these pneumonias, and many people survived this bacterial infection. So Fleming, I just vaguely remember the story. So two of his students and somebody, when they discovered Staphylococcus aureus, he was also interested in it. So what he did was he inoculated this into some culture plates before, and he goes on vacation. So he keeps all these plates which were inoculated in his laboratory at one corner where there was not much of, it was dark, not much of sunlight and all that. So on vacation he goes for 3 days or so, he comes back and sees. To his surprise, one of the culture plate or media which was not closed properly shows growth of some mold. And he just looks at it, and this culture plate, he had inoculated Staphylococcus aureus, but it did not show the organisms at all growing. He says, it's so funny. And definitely, you know, something would have come to his mind. So he had to go again on vacation, and what he does is he grows this mold which was there, and then goes. So after he comes back, he wants to know why Staphylococcus did not grow around this mold. So when both were there, inoculated in the same plate. So he tries now to extract the mold, something like the exudate, you know, that mold contents, and tries to inoculate this along with certain bacteria, and he definitely sees that Staphylococcus do not grow wherever this mold is seen. Then this had to be experimented on through clinical trials on the patients, and one of his medical student also, I think, takes it, and they try it on medical student, try it on a case of sinusitis. Nothing happens, and when a child was very severely ill with CNS infection was brought to him, what he does is he injects this extract of the mold through the spinal cord, and miracle, the next day he sees the child improving. So this is how the discovery of penicillin goes. You can read in detail history. I've just told you about this superficially. Why? Because some of you have definitely a scientific temper, mentality, and you would be in the process of discovering, inventing. Okay, MBBS is not just the end, learning all this. So contribute, do something more good to the society. Yes. So this is the lung histology, all of you have seen. This is the histopathology. Lung, these are alveoli. This is the alveolar septum. See, it is thin, it is not broad. Okay. So here the alveoli contain clear, they're so clear spaces, we say, that is air. Whereas here the alveoli, instead of air, they contain something else. So invaders. What is it? This is the exudate. All these are neutrophils with fibrinous strands. So this is how pneumonia appears microscopically. Then etiology, streptococci, most common, Klebsiella, pneumococci, staphylococci, and other gram-negative bacteria. So these enter the lungs either by inhalation or aspiration or hematogenous spread or directly. Yes. So you're going to learn about this in detail. When we teach you systemic pathology, we have just taken this as an example. of acute inflammation, but still I'm just giving you more information, not just the gross and micro, because this is an online class. I have enough time. You also have a lot of time to sit and listen to the lecture and learn. Okay. So morphological features, Lennox original description divides lobar pneumonia into 4 sequential pathological phases. What are they? Stage of congestion is the initial phase. Red hepatization is early consolidation. Grey hepatization, resolution. So this example, where during repair we used to tell students, this is one condition when the resolution occurs, so the lung is totally restored back to its normal structure. We do not see scarring and all that if there is resolution. So if you go back and see that lung, it becomes so difficult to appreciate which part of the lung was involved in this acute inflammatory process. But otherwise, if complication occurs, we say carnification also. Entire lung could be like a fibrosed tissue. So this is lobar pneumonia. This is the normal lung and this is the abnormal, the pathological lung. See, normal lung has so much of carbon you can make out. So when the pathology sets in, see, relatively the amount of carbon appears less. This is one clue for us to say, oh, lung parenchyma is appearing abnormal and grossly. So entire lobe is involved here. It is grey-white and appearing quite firm. So if we just look at it, we are not able to touch it. If we just look at it, it looks like liver, right? That's why it's called as hepatization, liver-like. Then lower lobes are more commonly involved. So let us see the first stage, that is a stage of congestion. Congestion, all of you know, where the capillaries are engorged. That means they're dilated, filled with RBCs. So that gives rise to enlarged, that is, the affected lung appears swollen, it is enlarged, it is heavy, so much of fluid that is there in it along with the inflammatory cells and the causative organism, and it is dark red. And what comes out when we cut? The same thing what I told you. It exudes blood stain, frothy fluid. At this stage, patient may complain of chest pain also. Pleurisy, we say, the surface, pleural inflammation. So, and he complains of coughing, rusty sputum also. So microscopy at this stage, that red color was due to congestion. So alveolar septa, you can make out septa appear dilated here and lot of congestion in the alveolar septa, widened septa. And the alveolar lumen has only edematous fluid and with few inflammatory cells. But if we examine this fluid, it shows presence of plenty of bacteria at this stage. And the fluid is so thin, that's how it permeates. It just enters into the next alveolar. We know about the pores of Kohn. So that's how the thin fluid keeps on spreading, and this is how it spreads into the entire lung, involves a large portion of the lobe or the lung. The diagrammatic representation. So this is the lobar pneumonia. One lobe is involved. Stage of congestion. This is the initial phase 1 to 2, and the congested blood vessels which are shown. Alveoli containing eosinophilic fluid and only few neutrophils but many RBCs, and this with the gram stain we can demonstrate a lot of bacteria. Next stage is red hepatization. So the lung still looks, the lobe looks red, but it is becoming slightly firm in consistency because of the inflammation. And whatever, so much of edema was there. Now the cut section is airless and it appears quite granular, and if you just feel, it is firm, consolidated, it looks like liver. So microscopy, make out the difference between the previous slide I showed and this. So inflammatory cell have, the number of cells have increased. Okay, slight, that the septal edema has come down. That means congestion has slightly reduced, and we are seeing this fibrinous inflammation starting. It is the exudate getting accumulated within the alveoli. So many neutrophils. So if we do a special stain, we can demonstrate the bacilli, the bacteria within the neutrophils also. So capillary, this is the septa. It's not that prominent compared to the previous one. So this is how the red hepatization is. It's about next second half, that is 2 to 4 days. And on the surface of the lung, that is pleura, we see pleural inflammation. See now, both red and blue. That means so many cells have come in. Okay. Yes. So this is red hepatitis. Oh yeah, this is becoming still fibrine. It's a later stage. Okay. So you can make out lot of cells. Next stage is red-grey hepatization. So here that congestion has come down. See, red color, it has changed to grey color. That means there is less vascularity here. Lot of exudate that is present. And cut section is quite granular. This is the cut section what we are seeing. The entire lobe is involved. It is granular, liver-like consistency, grey in appearance. Microscopy. So this is a stage. We are going to show you the microscopic slides. Stage lobar pneumonia in the stage of grey hepatization. So these are alveoli. Now alveolar septa, okay, it's not much seen here. This is alveolar septa. Look at the alveolar lining, and alveoli contain inflammatory cells, and the pink ones are threads, fibrin threads. And what's happening? So slowly, the organisms become less numerous and the cellular exudate, see, it is getting contracted. It is getting separated from the alveolar wall. A very clear space you can make out between the exudate and the alveolar wall. And macrophages also start appearing. See, this is a typical appearance of grey hepatization, lobar pneumonia in grey hepatization. So resolution. So the previously solid fibrinous constituent which was there, so all that needs to be cleared, so that gets liquefied and macrophages start clearing it. So normal aeration would be restored. See, this is undergoing resolution. You can see only few inflammatory cells, very little exudate. All the rest of it is being cleared. Okay, macrophages do it, or we cough it up and then it gets cleared. And macrophages may be prominent at this stage, and there could be few engorged alveolar capillaries. So the lung would be restored to normal. So about 1 to 3 weeks. Can you make out which part of which lobe of the lung was affected? No, this is almost looking like the other normal lobe. So that is resolution. But do remember, many cases land up with complications. What complications can occur? Pleura. The pleura is inflamed, yes. So pleural effusion, whatever inflammation is there, it extends into the pleura, causes effusion. And if lot of pus accumulates there, it causes empyema. And localized, when you're seeing so many alveoli with neutrophils and exudate, there will be tissue destruction and it forms a localized collection of exudate, pus. What do we call that as? Abscess, lung abscess. So that's how that can spread through blood to different organs. So there could be bacteremia leading on to septicemia. Then anywhere this septic emboli can be carried through the bloodstream. So if they totally block one artery, then they cause septic infarction, okay, septic emboli. Otherwise, septic arthritis, meningitis, endocarditis, pericarditis, etc. So these are the complications. But remember, resolution, the lung function is totally restored to normal, however, how it was earlier. So this is in brief about the knowledge. So once I give you the knowledge related to this, you will be able to appreciate the gross and microscopy. So I'll show you the gross specimen, then we'll see microscopy. Yes. Now we say about 15%, or more than, I think more for this second wave, COVID-19 cases showing severe cases showing pneumonia. Okay, so this is the specimen that we are going to show you. Is it pneumonia? What stage of pneumonia is this? Can you describe the gross appearance of this? So let's see the microscopy. Let's see the microscopy of lobar pneumonia. Okay, I'm already in high power. Let me go to the low power. So these are the alveoli. Okay, can you make out? See, alveoli of varying sizes. Normally we expect to see a clear space in it, maybe with few macrophages, that's all. Okay. So here the air is replaced by the presence of exudate. So what does this exudate consist of? So here it is the neutrophils, maybe few macrophages and lot of fibrin. Okay. So can you make out these cells? What are they? They all have black pigment, carbon pigment. So carbon-laden macrophages. Okay. What is another finding or feature you can make out? So this is the single alveolus we are considering. This is the exudate. Can you make out a space between the exudate and the alveolar wall? Okay. This is typically that is seen in stage of Grey Hepatization, where the fibrin starts contracting. See? Let us see a lot of areas of this. Entire slide we are seeing, I'm changing the fields, and almost all the fields we are seeing the same stage. This is a higher magnification. Now you can make out these fibrin strands. And all these are the neutrophils. See the lobations you can make out. See? Okay, this is the exudate. This is the clear space we are able to see in between the alveolar wall and the exudate. See congested vessels there. See here. Just trying to show you this under higher magnification. May not be that clear. Yes, this is clear. Okay, all this. Slightly, this slide was faded, so I've restrained, and that's why it doesn't have much clarity of neutrophils. But this is the exudate with fibrin, so just contracting. So let us see another slide now. Only higher magnification. I'm just trying to show you the exudate along with the fibrin strands. Neutrophils were so well seen in acute appendicitis, right? This is a large vessel. Look at the lining of the alveolar wall, the cells. Okay, so this is about microscopy of lobar pneumonia. Okay, let's draw a diagram of lobar pneumonia. Okay, circle. What we are showing here is alveoli. So alveoli, you know, are of different shapes. Okay, I'm writing alveoli here. Yes. So look at the septa. Septa are quite narrow. So in between. Yes. Okay, I have not shown widened septa. So let us draw one or two capillaries in the interstitium. This is the interstitium. Capillaries with, of course, endothelial nuclei, and fill them with RBCs. Use orange or red color pencil. So what am I writing now? You can see the alveolar lining. You have learned histology. You know the alveolar lining cells. Okay, fill it up. Take some time. Nicely write the lining cells of alveoli. Yes. So important is within the alveoli, we are going to write neutrophil, exudate. We are going to show the presence of exudate. Okay. So I'm just writing the nuclei for the alveolar lining cells. Okay. So I have taught you how to write neutrophils. Okay, whichever way. You can put an outline of the cell and then draw the nuclei. But here I am just showing segmented nuclei, most of them having 3 lobes only. And then I'll write the cellular margin using the same color. Okay. So fibrin, using eosin pencil to draw or to show fibrin. And observe now, I've just written these cells and exudate only in the center, leaving a space between the exudate and the alveolar wall. Okay, now this process goes on. So take some time to draw neutrophils exudate within the alveoli. Hardly some 7 or 8 alveoli I have written in one high power. Just drawing the nuclear configuration, showing the nuclei. So then I'll show the cytoplasmic or the cell wall, the outer margin of the cell. So you can use eosin or hematoxin pencil only. Yes. So the rest of the alveoli also we need to write the same. So this is a specimen. What specimen is this? How does it look? Yes, it is lung. Okay. So you can make out the lung tissue here, which is black in color. This is what we expect, So lung, which is usually dark, and the color the black color depends on where we stay, what occupation, etc. Okay. So this looks like two lobes here because there is a fissure separating the lobes. So what is the change that we are seeing? See, have a close look. So the lung has, see, these are the bronchioles, the major bronchi you can make out here. So much of white areas here, and lung is normally having a pillowy consistency, very soft, but it looks that consistency is lost. We are not touching here, but we can make out. Okay. And what is the color? All these areas, don't you think they are looking like liver? It is looking like liver. Yes. So this is Grey Hepatization. Okay. So it has involved, this is lobar pneumonia with Grey Hepatization. It involved the entire lobe and then major portion of this lobe. So well we can appreciate this. So once there is a pathology here, all the carbon pigment looks displaced. That means there's some pathology in between which is making the carbon pigment appear less compared to this. So this is a specimen of lobar pneumonia in Grey Hepatization. So this is the surface. That is a pleural surface. We have just mounted one slice. Can make out even the pleural surface. Normally the pleura has a glistening appearance. It is shiny. But here you can make out it appears quite thick, and pleura also is inflamed. See, look at the surface, pleural surface. So the pleura is also grey white. Here you can appreciate the thickened pleura. The parietal, this is the visceral one. Okay. So this specimen is lobar pneumonia in Grey Hepatization.